Today we shall look at the case of the week. This is a series we shall be looking at every week. Every week we shall be dealing with yet another interesting case. I wouldn't advise you to miss for any reason. Lots of these will be on our website. You can always go there after the recording and then you have a look. I will start by reminding us how to make a good radiology report. How do you go about interpreting an image? Again, I will start by reminding us how to make a good radiology report. This mainly is aimed at our radiographers or our imaging technologists or even our student radiologists who find themselves with these images but they don't know how to interpret them. Today, we will make it easier for you. How do you go about interpreting an image? Right here on the screen, it's usually advised that you systematically look at the different aspects of this chest. That will give you the information. So you systematically look at each and every aspect of this chest and make sure it's just like a checklist. You tick it and say this is okay. But when you are writing a report, I wouldn't like a report to be written in that form. Like for example, here on the screen, I have put a way or an order through which you look at the different aspects. If we consider the different aspects, for example, we have the chest wall, we have the pleura, we have the hemidiaphragm, we have the mediastinum, and we have the cardiac shadow. The temptation usually, many people want to report by start saying that the chest X-ray is normal, the pleura is normal, the hemidiaphragm, then they state the pathology. But that is not a very interesting way, especially the doctors who are going to read your report. We would like to start with where the pathology is. What am I trying to say? I'm trying to say that if you quickly look at a chest radiograph, yes, it's good to go systematic. Yes, look at that chest wall quickly. See if it is thickened, if there is any alteration in density, like we see in the subcutaneous emphysema. Then go quickly to the bone prominence, the bone aspects of that chest wall, look at their densities. Do we have any fractures? Do we have any widening of the interrib spaces? Then you quickly go to the pleura. Is there pleural effusion? Is there pleural thickening? You are systematically looking at everything. And of course, you want to look at the hemidiaphragms and also the cardiac shadow. And then finally, you end by looking at the lungs. The lungs are looked at again in a comparative way. You compare the left and the right, and you want to say, some people put a paper, and you want to say this should correspond not only in density, but also in sizes. And this may be a hint as to what is happening to these lungs. However, when you get a pathological one, like for example, in that case, in that image 1, you already can see that we have a pathological one. It is important to look at all the aspects of this radiograph. For example, as I stated earlier on, I said, yes, we can look at the soft tissues of this chest wall. We can look at the bony structures of this chest wall. And of course, also we go inwards. You see, I'm trying to interpret from outwards, inwards. And I've looked at the bony prominence, and I've looked also at the hemidiaphragms, then the cardiac shadow and the mediastinum, then finally the lung fields. It is imperative that before you write a good report, to try and list all the pathologies that you see before you write the report. So here, when you look at this radiograph, it has several pathologies, and in order not to forget any, you start by listing them down. For example, you quickly mention the technique. The technique is very important. You note that the patient was rotated, as you see there in the image. And then, of course, quickly you note that there are those bilateral alveolar infiltrates. This is what I'm referring to. You also note that there is bilateral mid and lower zone nodular infiltrates. These are the ones that I'm referring to, those ones there. And I think everyone here can note them. In case you can't, you are not able to note them, the advice is to try and magnify the image as much as you can. Nowadays we use CRs and we use digital radiography, so the image can be manipulated digitally. So that's not a limitation. So if you can't see some features very well, please magnify your image. Then when you look at this hemidiaphragm again, on the left we see that it is ill-defined, probably due to that lesion there, and also on the right you see that tenting, they call tenting. Then finally, in both lung fields, especially in the upper zones, we notice those lucent areas, especially more marked on the left there where the cursor is. You see that lucent area which is free of any lung markings, and that's where we say this could be a pneumothorax. And of course we also note that air fluid levels. So in a nutshell, you have all those features. These are features which are in this radiograph. You have put them down. Now you're going to compose your report, and your report should include each one of them. And when you read through your report and there is one missing, again you are advised to go back. So what would the report look like? A report sample is there. It's not the gold standard, but it's a proposed report. You could modify it accordingly. And this one just says there is ample imaging with slight rotation to the right. They are bilateral diffuse alveolar infiltrates with air bronchogram and silhouette sign confluent in a few areas. Interspersed and evenly distributed are discrete nodular lesions in the mid and lower zones bilaterally with even sizes and densities. Increased region or increased region more marked on the left with the paucity of the lung markings and slight mass effect on the underlying lung tissue, slightly deviating the mediastinum to the right. A definitive small air fluid level is demonstrated on the left, that one I showed. There is tenting of the right hemidiaphragm. Of course, there is the left is ill-defined with the probable cavitating lesion. So in conclusion here, we would say these are features of extensive cavitating bronchopneumonia with mild bilateral upper zone tension pneumothorax. PTB is a likely cause, and we would suggest a CT scan. Now, you realize in this case, I have derived all the features that I showed up here in this radiograph, and I started by noting one of them, and I don't want each one of them to be missing in the report. So that's why I list them here. Okay, and I could go back in my report back and forth and make sure that everything that was listed here is in the report. Okay, just to recap again, when we are writing a report, first and foremost, we systematically look at the image and different aspects: the chest wall, the mediastinum, the cardiac shadow, mediastinum. So each issue you find here, you can record in a systematic way before you can compose a report. So that, ladies and gentlemen, is the report for that image. When I go on and I look at the second image, again, you'll agree with me that this second image is not the best of quality. Of course, there is that preferential alteration in density. Probably the patient was not straight, but this was one of the children. She was a child, and usually it's difficult to get an appropriate image for children. Most of the times we use what we have. In this case, you also realize that the corns were opened, and we can see quite a bit of the hands and then also the chin. But that notwithstanding, there are some features here which we see. What do we see in this radiograph? Again, like I said earlier on, quickly you look at the radiograph and look at the soft tissues, look at the bony prominences, the bony structures in that soft tissues. Are there any fractures? Are there any alteration in density? Then you go on to the hemidiaphragms. Are they symmetrical? Are they ones higher? Then you quickly look at the mediastinum, and it is where we have the pathology, and we shall describe it. And of course, you finally look at the lung fields and you compare them. So after, instead of listing those other ones as normal, again we list the most important features that we see. And here again listed is the poorly done radiograph and rotated, and of course the coning also comes in. The significant finding here, of course, is that this right paracardial soft tissue, or you can say soft tissue shadowing, it seems to be paramediastinal, with a positive silhouette sign with the vertebra. We don't seem to separate the two. And of course, one would say also the margins, especially on the upper margin, are a bit ill-defined. This could be vesicular, we cannot know, and also this could be a bit of cephalizing. You may not comfortably comment on this cardiac shadow because of course it was a child and the patient was rotated. So in this case, when you look at this cardiac shadow, you don't want to say, but one gets an impression as though there could be an enlargement of this cardiac shadow. So what would our report look like? Again, a proposed report will be that the patient was rotated to the left, and the coning is inappropriate with visualization of the neck region and cutting off the left chest soft tissue. The major finding here, I like when you start writing a report, you bring out the main thing. There may be a lot of radiological features there. There may be these other normal, but in order not to bore, if I can use that word, the referring doctor, you want to start up with something that is of significance. And here it's always good, you can open up your sentence by saying the major finding here is the large, homogeneous, dense right paramediastinal tumor, like I was showing you, with ill-defined lateral margins and a positive silhouette with a spine. So whatever I listed down is included in my report. Relative cardiomegaly is noted and moderate left deviation. Otherwise, the lung fields, the rest of the mediastinum and cardiac shall appear normal. So these ones now come after. The final conclusion would be these features point to posterior mediastinal mass. Why is it posterior? Because of the positive silhouette sign with the mediastinum. Okay, that is why we want to say it is posterior. Of course, rule out lymphoma because it's a child, and then we want to do a CT scan and of course a guided biopsy. So in a nutshell, again, that's how I would advise that you approach that radiograph, comment about the quality, and start by highlighting the main findings here. Okay, good. The other aspect which I wanted to say as I go on to the third case is when you look at the radiograph, it's always good for you to come up with a differential, because if you have come up with a differential or what you want, even before you write it down, then it gives you the way you're going to systematically describe it. Of course, if I want the conclusion to be, like for example, in this case, an alveolar a consolidation, then I need to describe it accordingly. Okay, so that is what I want to say. Our third case is again a fairly well taken radiograph, but again, one notices that the slight deviation, rotation according to that increased medial aspect of the clavicle in relationship with the spinous process. But again here, one quickly wants to look at this radiograph and you say, I think this is this. Like for example, in this, you quickly say these are lung infiltrates. Like I want to conclude that these are probably pneumonic in origin. But again, like I said, to make a good report, you systematically look at all the other aspects of the chest wall, the soft tissues, bony structures, and the rest of. Then when you come to put down those important aspects of these radiographs, that's when now you say there is loss of the chest wall, soft tissues. Of course, we see that there is a bit of thinning. And then, of course, here also we see that there's near discrete bilateral alveolar infiltrates. These are almost near to discrete. They are not exactly as fluffy as we want them to be. Because once you say they are fluffy, then you have a connotation of acuteness. But if you say they are discrete, then someone reading your report will say probably I'm in the subacute or probably a healing phase. And of course, it is important in these pneumonias to look at the other complications, and one of them is a pleural effusion or a lung collapse, and so it's good to include it there as a negative. So, what would our report look like? Again, there is a proposed report, and then after commenting on the quality, one would quickly say that there is a near discrete bilateral airspace infiltrations, predominantly in the mid and lower zones, confluencing in a few areas with silhouette signs, what there is sign and air bronchogram. The upper zones are fairly spared. The cardiac shadow, mediastinum and chest wall are non-remarkable. So again, here it gives you the description which I was showing you earlier on, and I say these are the fluffy, mainly in the mid-zone, tend to spare the apices, and of course they have a positive silhouette with the medial aspect of the cardiac shadow. So these point, of course you can also say the air bronchogram, the presence of air bronchogram, which puts it more on the alveolar. So these are central alveolar infiltrates, and easily a subacute pneumonic consolidation or alveolar pulmonary edema and COVID pneumonia, all differentials. Here a CT scan is advised with the clinical correlation. That one will be a correlation. We correlate with the clinical. Okay, so that is the end of the second report. I'm going to give you 5 for this session. The second last is what I'm going to look at right now, and the second last report, of course, is derived from also one of our patients here. Most of these cases are actually real patients, and we derived them from our archive. Again, the first thing that I wanted us to notice is when you look at this X-ray, you need to conclude. You need to look at it and you conclude, what am I dealing with here? Quickly. And for me, when I quickly look with a dirty chest, if I can call it a dirty chest, with so many infiltrates, reticulolinear, they are both a mixture, they are linear, and also they are nodular, especially in the peripheral. Then I want to conclude that this is probably a metastatic process. Again, secondary infected probably with a pneumonia. These are all my conclusions. Then after I have concluded, then I have to go back and look at all aspects of this chest X-ray. Again, I want to start with the wall, the soft tissue. I want to look at the thoracic. I want to look at the hemidiaphragms. I want to look at the cardiac shadow, and I settle in with the chest. Now, on my right here, you can already see that I have put down a few things. Maybe some of you may not have noted it, but we are talking about nodular lesions and bilateral coarse reticulations with the scapula in the field of view. Of course, the radiographer here did not pull out the scapula in the field of view. Okay, so the report will read something like, there is rotation to the left but with ample exposure factor. The significant finding here again are the multiple bilateral well-defined discrete lesions of various sizes and shapes and densities, predominantly in the mid and lower zone peripherally. So these are the ones I'm talking about. If you look carefully there, these are the ones I'm talking about. And then you say a discrete one is noted over the right hemidiaphragm with a positive silhouette sign. That one over there. And someone probably would say a positive thoracic abdominal sign, which would point to a positive, a posterior lesion, giving a shaggy heart. The other major feature is the bicentric reticulation radiating peripherally and giving a shaggy heart appearance. Again, I'm trying to describe those other lesions which take up the rest of the chest, and of course we see the shagginess of the heart. Here we again conclude that these features are in keeping with metastasis and cannonballs. These are cannonballs, and this prominence in the reticulation could be also lymphangitis, carcinomatosis, or it could be a secondary infection, or it could be something which was already there before the metastasis. But what stands out here are those nodular lesions, and one would consider lymphangitis, carcinomatosis, or can consider a primary of choriocarcinoma or osteogenic sarcoma. In a nutshell, that is how this report would be written, and of course in an orderly way, that is how it will be written. Finally, for this session, again we have a very, very interesting case here, which we shall end with today. And again, we always want, when you get this image, to get your impression first. Then we say, when you quickly look at this image, of course many times we don't have the clinical history, but when you look at this image, something should go through your mind. And when you look at this chest radiograph, a few things to note first is that line. So we have that line and air-free level, and we have ill definition of those ribs, and this image was cut off, but where we got it from, there was a bit of subcutaneous emphysema. Okay, so and listed here again, if we go with what we were saying earlier on, that in order to make a good report, you should systematically assess all aspects of the chest radiograph. And here we start with the soft tissues. The soft tissues here were cut off, but there was a bit of subcutaneous emphysema, lucencies in the soft tissues, and of course we have rib fractures, definite rib fractures, and then when we go in, we have that air-free level, and of course we have probably hydropneumothorax, and of course the obliterated left costophrenic angles. So all these point to a traumatic chest condition. Of course the lateral also shows it very well. And then of course we conclude that in this case, this is a case of chest trauma with the above features. Now what remains is to wrap up, to put all these features that we have listed above, and we put it in a report form. And what would the report form look like? This is a proposed report form, and quickly we note that the patient was rotated and the cones were opened widely. The main finding again we want to hit first thing on what is making news, the biggest issue here, and then we say here there is marked reduction in the right lung volume with increased density. There is an air-free level in the lower aspects traversing to the entire hemithorax with relative lucent regions. The right chest wall soft tissues is thickened with multiple lucencies and probably adjacent rib fractures. A drain is noted in situ. Left basal haziness with obliterated left costocranial angle is noted. Again, these are features of a traumatic chest condition with left lung contusion, collapse, a hydropneumothorax, and subcutaneous emphysema, probably with fractures. Ladies and gentlemen, that ends our session for today. We've described 5 cases and we have showed you how to go about making a good report. Again, I'll just recap here. You systematically must assess all aspects of the radiograph. Then you list down those main features in each of the pathology, leaving out none. Then of course you put up this pathology and you ask your mind, what do I want to conclude? What do I want to say? And if you want to say it's traumatic chest, then you describe it accordingly. If you want to say it's a malignant process, then you describe it accordingly, according to what you have seen. Then you come out to write a comprehensive report, and it must include all the other aspects. Thank you for listening, and we shall meet again next week. Bye for now.